and welcome. My name is Angie DeMello, and I'm a member of St. James Catholic Church in Stratford, a member of CONECT's strategy team, and a member of and former co-chair of CONECT's healthcare and mental health care team. Deidre?
Again, thank you all for being here. You could have spent your time anywhere else, but this is important and you're important, and we thank you for your time. Before we get into the program, I want to give you some good news. Senate Bill 1019, also known as Clean Slate, has passed the Judiciary Committee. There is still work to be done, but that is a reason to celebrate for now. Now, let's get on with the program for tonight. In collaboration with Health Equity Solutions, we are honored to participate in Health Equity Week for this important conversation on race, ethnicity, and language healthcare data. In the chat box, you'll see that there's a link to our agenda. I invite you to open that up and follow along with us. Through the conversations tonight, we will answer questions regarding race, ethnicity, and language healthcare data, which we will refer to as REL going forward. Our goal tonight is to understand the importance of this foundational step in addressing healthcare disparities. At the end of today's meeting, we will be asking that you support us in helping others understand the importance of REL, providing your own data, and writing to your legislators. Thank you, Health Equity Solutions, our panelists, all of you who are here tonight, CONECT leadership, as well as our chat monitor, Yolanda Skinner. So if you have questions, if you have concerns, we do ask that you put them in the chat, and Yolanda will be monitoring that through the night. So now let's begin with a poll to understand your experience with data collection. A few more seconds and you want to launch the poll. Those of you still voting, we invite you. Okay. So I see the results. Out of those of you who have voted, 80% of you, 33 of you, have been asked for REL information in the doctor's office. So you have some experience with what we're talking about tonight. We're going to share how important that data is. Angie, we're going to launch the second poll and you will give them those results, right?
Of course. The question was, if you were asked for your REL information, did you provide it or did you refuse to do so? And the answers are telling. 44 of you, or 85%, said yes, and 8 of you, or 15%, said no. We hope to show you the importance of providing these numbers during tonight's conversation.
Thanks, Angie.
Of course.
This past year, we've collectively witnessed and experienced mass suffering. We have grieved and continue to grieve, largely in isolation from one another. We grieve the 545,000 lives lost to COVID in the United States and the 7,923 lives lost in Connecticut. We grieve the loss of life of countless people of color whose infection with COVID-19 may not have been fatal had they received adequate treatment, had their pain been believed, had they not been denied a COVID-19 test or a hospital bed, had they not been turned away. We grieve the lives lost and fear felt in the dramatic rise in hate crimes against Asian Americans and Pacific Islanders. Weeks ago, the mass killing in Atlanta claimed 8 lives. 6 of them were Asian American women. We say the names of those lost in remembrance: Soon Chung Park, Yin Jung Grant, Sun Cha Kim, Young Ue, Delaney Ashley Ewen, Paul Andre Michaels, Xiao Che Chan, Dao Yo Fang. Discrimination against Asian Americans is not new, but in the past year, it has been heightened. We condemn this discrimination and mistreatment as a symptom of white supremacy. There's so much that we must do to rectify injustice in all its forms. We're here tonight to discuss the life and death crisis of racial disparities in our healthcare system, and one specific way we can begin to address this injustice. It is the collection of race, ethnicity, and language healthcare data known as REL or REAL. Angie, would you introduce us to our panelists tonight?
Absolutely. Thank you, Deirdre. The purpose of this legislation is to collect healthcare data by race, ethnicity, and language to better understand healthcare disparities in Connecticut. We know from anecdotal evidence and existing data that race far too often predetermines health outcomes in our state. The life expectancy for someone residing on Colorado Avenue in Bridgeport is 70 years. Life expectancy for someone residing on Highwood Road in Westport is 89 years, a 19-year difference. This is the story of healthcare in Connecticut, and sadly, we don't even have sufficient data to fully explain this discrepancy. Through legislation SB 1, REL healthcare data will be collected in a macro way. This simply means that no individual names or identifiers will be tied to this data. Its purpose is purely to illuminate demographic healthcare trends. It is also critical to note that while providers will be required on patient intake forms to include REL demographic questions, patients who are uncomfortable in disclosing their race, ethnicity, or language will not be required to answer. These questions are purely optional. The initial vehicle for passing REL healthcare data collection legislation this session was House Bill 6424. During the public hearing for HB 6424 in early March, 6 Asian Americans provided written and oral testimony expressing concern about data abuse and discrimination. we hear these concerns. They are tied to a long history of oppression and discrimination against Asian Americans in this country. However, we must emphasize that in this moment, we are still in the midst of a global pandemic that has disproportionately ravaged and claimed the lives of Black, Latinx, and Indigenous people in Connecticut and even across the country. The fact that the pandemic has not impacted all communities equally should not surprise anyone. It is sadly and devastatingly in line with historical and current healthcare trends. Given this, we must take action to address racial and ethnic health disparities in Connecticut. This is a matter of life and death, and data collection is the necessary first step. Tonight, we will hear from our panelists. Ms. Vicki Veltri, Executive Director of the Office of Healthcare Strategy for the State of Connecticut. Dr. Greg Gonzalez, Yale Law School professor and co-director of the Global Health Justice Partnership and the Collaboration for Research, Integrity, and Transparency. Reverend Robert Anderson, ordained elder in the in the African Methodist Episcopal Zion Church and director of the Ministerial Health Fellowship. Professor Thomas Buckley of the Yukon School of Pharmacy and clinical consultant for Kaima Health Advocates. Reverend Nancy Kingwood, Executive Director of GBAP, Inc., a member of the Health Equity Collaborative. The conveners are Health Equity Solutions and the Connecticut Health Foundation. And I'm going to put a little caveat here. If Miss Ramsey is here, Miss Lorraine Ramsey, she is an advocate and leader with CONECT's healthcare and criminal justice reform teams. She had informed us earlier that she might not be able to make it. Thank you again to our esteemed panelists for being here tonight. Interesting. Among our panelists, we have 2 pastors and 2 professors, and we know you all can talk. Just a little bit of housekeeping. Our timekeeper tonight is Beth Stiga, who will let you know when your time is up. Beth, could you ring your chime so that people know what it's going to sound like? Oh, that's great. Thank you, Beth. Each panelist will have up to 5 minutes or less to share from their perspective why REL data collection is so critical to achieving equitable health outcomes, and especially in this moment, why we need to pass REL legislation. Once again, each panelist has, once each panelist has had a chance to speak, we will facilitate a discussion amongst all panelists. And to our panelists tonight, please take a moment to tell us how you came to care about this topic and about the work you do in healthcare, in the community, and your own experience. From your perspective, please give us the reasons why you feel this data is important and how it can shift health disparities in the community. Ms. Veltri, let's begin with you.
Thank you, Angie, and I'm honored to be here tonight. with CONNECT, with Health Equity Solutions, and thank the Connecticut Health Foundation also for its support of the ongoing work. Been a partner with CONNECT for a long time on many issues. And while I direct an office at the state of Connecticut, whose mission is really about improving health outcomes for everybody in the state, that means every single one of the 3 million people in this state. I come at this, I think, from my earlier career as the healthcare advocate for the state of Connecticut, and as a legal aid lawyer, where I saw incredible disparities in access to not just healthcare, but access to housing, access to conditions that affect health. So it's become a critical issue for us to collect race, ethnicity, and language data, particularly at the provider level, where we think it's critical to improve healthcare coordination when people move from provider to provider, but also to measure how we're doing. You know, how are we performing as a state in delivering quality care? We know from statistics that are kept by the Department of Public Health and from our own work that there are incredible disparities in the state of Connecticut in terms of access to care, but also outcomes, particularly in areas of diabetes, asthma. There are many others that show up repeatedly. And it's not just in these health measures, but also access to insurance coverage, access to healthcare coverage in general. And what I've said, and I will say repeatedly, is we cannot improve what we do not measure. So it is really critical that these data be collected at the point of care if someone chooses to provide it. And that's a very important if that Andrea and both DJ and Andrea brought up earlier. Is this is voluntary data collection, but it's important to examine at a system level so that when we decide on policies at a state level, we're not looking at data at this level by race, ethnicity, and language. We need to do that if we're going to improve these outcomes. We design policies a lot without looking underneath the hood at the impact of those policies. I'd rather design a policy with the input of communities based on community composition and what people are experiencing in their lives. That's why we think it's absolutely critical that our legislation go forward this year. My view is if we can't do this year, when are we going to be able to do it? If we can't do this after seeing what the impact has been in COVID, and even before COVID, quite honestly, but COVID has obviously magnified the disparities we feel or we're experiencing as a state. We can't do that now. I'm not sure when the time is. So I'm committed to this bill, our bill, and also SB1 and other bills, and we will continue to dedicate ourselves to ensuring passage of these data collection this year so we can start improving right now. So with that, I'll just turn it back to you, Angie, and let the other panelists go. So thank you so much again. I'm so happy to be here as part of Health Equity Week.
Ms. Veltri, thank you so much. I hear you. You're saying design a policy with community in mind together and pass it this year. So thank you for that. And now we're going to ask Dr. Greg Gonzalez. Would you give us a brief synopsis of how you came to care about this topic and the work that you do in healthcare?
Thank you very much, and thank you for inviting me to be with you tonight. So you said I'm a professor at the Yale Law School, which is true, but I'm also a professor at the Yale School of Public Health, which is probably more relevant for tonight. But even more relevant than that is, for 30 years, I've worked on the HIV/AIDS epidemic in the United States. It's deja vu all over again, right? The AIDS epidemic struck communities of color, people living in poverty, far greater in the United States than the general population. And so these health disparities are not new. They're not new for diabetes, they're not new for high blood pressure or breast cancer or a whole host of health conditions that were with us way before COVID even was on the scene. And so the importance of health equity has been central to my work as an activist for 30 years. And then as I came into sort of an academic climate only a few years ago here at Yale. A couple of things. One is we wrote a piece called The Fierce Urgency of Now, Closing Glaring Gaps in US Surveillance Data on COVID-19, actually about a year ago, April 14, 2020. And it talked about how across the United States, we were not collecting the data we needed to collect on cases, hospitalizations, deaths, tests, test positive, test negative, test performed, a whole range of health indicators were not being collected at the level we needed to do, which is not just the state level, but the county level, the town level, and the census tract level over time, right? So we need data that's on race, ethnicity, gender, age, etc., over time, right? And down to the lowest level of geographic aggregation as we can possibly do. That was in April 2020. So in October, November 2020, a group called Resolve to Save Lives came out with a report on essential indicator availability for COVID-19. And you can go look at their website called preventepidemics.org. And they gave our state, Connecticut, a 20% score on indicator availability. Cases, tests, and positive, syndromic surveillance, hospitalizations, congregate facilities, deaths, test time, isolation. This is even before we were talking about vaccination. And so we were doing pretty poorly, even as we entered the fall with 6 months of the pandemic under our belt, right? To be fair, not a lot of other states were doing much better than we were. But the point was we did not have a robust data infrastructure to track our epidemic here in the state of Connecticut. You know, I was on the Connecticut data portal this afternoon, just looking through what you could get at the level of census tract. There's nothing that's publicly available. You can get data by town, but it's not disaggregated by race and ethnicity. You can get longitudinal data on race and ethnicity over time, but none of it comes together across all those tabs to give us fine-tuned data on how this pandemic, how in fact all health issues are affecting our communities at the grassroots level. We know from the towns we live in that from neighborhood to neighborhood, your fortunes can shift and whether you get sick or well, whether you get access to care or you don't get access to care. If you look at the vaccine numbers in Connecticut, we've been very Connecticut's doing well about scaling up vaccines in Connecticut, but if you also look at the race ethnicity data, almost across the board, if you're a white nutmegger, you're going to be getting access to vaccines in far greater proportion population than African American, Latino, and other racial demographic groups in the state. We're not doing well on closing the gap in vaccine access in the state. But as the previous speaker said, what gets measured gets done, right? And so if we have the chance to get data systems in place in Connecticut, it's vitally important, right? You know, yes, all the downstream things, treating, preventing disease are important, but if you can't figure out what's happening in the state of Connecticut, town by town, block by block, it's really hard to pinpoint where our efforts need to be done. So we need to invest in that. And supporting this bill is important. There's also the American Rescue Plan, right? You know, millions and millions, in fact, billions of dollars are flowing directly to states and localities, often to sometimes NGOs across the country. And we should ask the governor, ask the Department of Health to target some of this money now for boosting our public health information systems across the state. As Vicki said, we can't wait. And we don't have to just wait for the bill. There's money that's coming that's pretty fungible. It's not targeted in very discrete ways, and it's no year money. So we can use it this year and next year and the next. So we should be really targeting our efforts to make sure that we can enrich our data structures across the state today and tomorrow, not wait for the end of the year to let this happen. I think I heard the bell.
Yes.
Dr. Gonzalez, thank you so much for sharing your insights and your on-the-ground work that you are doing, that you are so immersed in. Thank you. REL, we all know, or at least we all are working towards making REL that important piece of the picture. Thank you. And now, Reverend Robin Anderson, we would like to hear from you.
Good evening, everyone. So thankful and grateful and humbled and honored by the Connecticut Health Foundation, CONECT, and also the Health Equity Solution for convening this panel discussion. My name again was Robin Anderson, and I'm the director of the Ministerial Health Fellowship. And the Ministerial Health Fellowship is an advocacy coalition that advocates to address health disparities, but also for healthcare policy changes as it relates to the Black and Indigenous people of color population. And so a great part of the work that we do is to continue to bring to the forefront those disparities, of course, that not only have been going on since COVID-19, but actually were way prior to, for over 400 years to be exact. And also the fact that policy changes, if we're really serious about really at this time declaring racism as a public health issue, and to really once and for all address these things, but also not just by what we say, but also putting the dollars forward that need to be there. As far as the race, ethnic, and language data is concerned, I am really concerned about that, because one thing that I know is that we will never be able to really adequately address the health concerns of people of color unless we have a way in which we standardize the way in which we collect data. Yes, we do know that there is a disproportionate amount of people of color that have diabetes, that have high blood pressure, that have a heart disease, as well as strokes. But yet and still, we really don't know what that really means in terms of the data. And also really, I believe that it also interferes with the amount of money that we actually pour into those particular areas to address those persons of color, so that they, and not only in the way in which the healthcare system addresses those things, but also how much funds are actually put in to various areas to address it. And are there adequate funds that really address the healthcare needs of people of color, if we don't know how many people of color have various diseases and we don't have a standardized way of collecting that data? The other thing that I want to also mention, the fact is, yes, some of it is environmental. Also, we know that it's also been redlining and those kinds of things as well. Again, how do we address those things unless we have a standardized way of collecting data and making sure that environmentally we make sure that we address some of those things as well, so that people of color will have improvement in their health conditions. The other thing is access. People of color really have concerns about accessing the healthcare system because of the way in which they have been treated in the healthcare system, and also the way in which they're not necessarily feel that their health concerns are addressed, or sometimes even misdiagnosed in many kinds of ways. And I can say that because even as a person of color, I am African American, and I'm also Native American. And so I developed an eye disease in which I'm legally blind now. And so for a while, they could not find out what it was. But not only that, I was also found without insurance because of a financial situation in which the place that I worked at had not paid the premiums. But what was the most significant thing was that they never looked for the eye disease that I had, because they only thought that I was African American. And the eye disease and the rare eye disease that I have was only found in people that are African American and also have Indian ancestry. And so when one of the doctors mentioned that to me, that we think this is, but it doesn't look like that because it doesn't usually show up in some, I said, well, I am African American, I am Native American. But of course, because of the way in which we collect data, and also the way in which we identify ourselves, they did not know both of those kinds of things. So again, I think that it's important that we standardize it in a way that also you can also, again, myself, that I've also experienced, that you can misdiagnose those things. We also know that people die, people of color die at such an early rate, or early age, more so than our other counterparts. Well, a lot of that has to do also, I think, again, without standardizing data and not being able to address some of the health conditions in a way that's adequately needing to be addressed, because we don't have data that actually states that. And so we don't really not able to address those kinds of things. And so I also think that it's so important that we continue to really look at, if we're serious about dismantling structural and systemic racism, that we really pass the bill for collecting race, ethnic, and language data in a standardized way, so that people of color have a great opportunity and great chance to get the health care that they need and also have the dollars to go to where they need to go to also, even as it relates to social determinants of health and all of those things that will continue to keep people of color healthy. Thank you.
Thank you, Reverend Anderson, for your work in making changes in healthcare policy and your focus on equity for people of color with regards to data and funding. Thank you.
Yes, and we appreciate your presence tonight. We'll now hear from Professor Thomas Buckley. Please tell us how you came to care about this topic, REL, and the work that you do in healthcare.
Well, thank you, CONECT, for inviting me tonight. I truly love the work that you're doing. And I say this coming from a sister organization as the co-chair of the healthcare team for the Greater Hartford Interfaith Action Alliance, or GIA. We work similarly on issues, so I really appreciate the work you're doing. My clinical and research area of focus is refugee and immigrant health. And to that end, I've worked with Khmer Health Advocates in West Hartford for the last 15 years. They're a community-based organization that delivers mental health services to survivors of the Khmer Rouge genocide, and they've been doing this since 1982. I've also worked in Burmese refugee camps on the Myanmar-Thailand border multiple times, and in Cambodia with the Cambodian Diabetes Association. So I really want to focus the REL issue with specificity to Asians in Connecticut. And I know this is a particularly controversial area at times, so I appreciate the fact that you've addressed this up front and that we specifically look at data, because we think that the lack of disaggregated data under the category of Asians, just Asians, represents a significant health inequity for the Southeast Asian communities. When I first started working with Khmer Health Advocates 15, 16 years ago, we had a national retreat in Connecticut with Cambodian American leaders from all around the country. All of these leaders were survivors of the Khmer Rouge genocide, one of the worst genocides in human history. Just to give you a sense of how bad that was, the Khmer Rouge held power from 1975 to 79 and killed 1/3 of the Cambodian population during that time, and even more tragically killed 90% of the professional class. So anyone with education, business persons, clergy, even getting to the point of targeting people with eyeglasses. So community leaders shared with us numerous messages from their time held captive in the Khmer Rouge, which were just heart-wrenching. Things like the Khmer Rouge embedded into their mind to this day phrases like, to keep you is no gain, to lose you is no loss. Be like the kapok tree, remain mute, because the kapok tree is a tree in Cambodia when the wind blows, the leaves make no noise. So this is, you can imagine, a healthcare provider now seeing Cambodians as they've been immigrated with those two messages in their mind, the challenges that brings to healthcare providers in Connecticut. So the message that struck me most, though, in that retreat was when the leaders told us that they knew their community had high rates of PTSD and high rates of depression, but they were dying from diabetes. And they were right. But we had no data on diabetes, especially none on diabetes of Cambodians in Connecticut. We had no health data on Cambodians in Connecticut. If you spoke to any healthcare provider 15 years ago, and many today, they would be very surprised that their Cambodian patient was at a very high rate, very high risk of diabetes. And they'd be even more surprised to know that the rate of diabetes in the Cambodian American population is 4 times higher than the American population. Overall, their chronic disease rates are extremely high. Hypertension is 3 times higher than the American population, depression 10 times higher, PTSD 15 to 20 times higher. But this is all data we have from California. We later confirmed this with the surveys of our own in Connecticut, but not true hard data that we're collecting through medical record systems. So all of this has led to Asians have fallen prey to what's known as the model minority myth, that all Asians are doing well on various socioeconomic measures of wealth and well-being. This occurred, Americans became the model minority after changes in the 1965 immigration law, which allowed large numbers of educated immigrants into the US, many highly skilled South and East Asian nurses, doctors, and engineers, predominantly from India and China. And this myth of the model minority has worked to the disadvantage of the many of the what's referred to as subgroups, which is almost a derogatory term, subgroups who have been subsumed under the pan-ethnic category of Asians. So we've seen that even 40 years after the Khmer Rouge and the time they spent in refugee camps, that these histories of traumas have made Southeast Asian Americans more disabled, sicker, more prone to early death. But the only data we had available, again, was from California. We knew that data shapes the planning, the implementation, and the delivery of services to specific ethnic groups, but we just couldn't get it in Connecticut. So when we seek funds for research on health problems suffered by these minority subgroups, it's very hard for funders to say, show us your data, to say that you've got a justified proposal. All grant proposals start with a needs assessment. And without disaggregated data that describe the nature and the scope of the problem, researchers on AAPI, Asian American Pacific Islander subgroups, we can't justify a need for this funding. So resources are rarely allocated to solve problems experienced by smaller groups such as Southeast Asians. They're essentially invisible in the data. And we're seeing this again. I'm glad this was brought up in return with regard to COVID, because when you look at COVID cases and deaths and COVID vaccination rates, you see the Asians doing quite well in that data. Do we know this to be true in the Southeast Asians? We don't know. What we do know is that data historically tracks that health and health access tracks with income levels and education levels. Well, in Connecticut, only 14% of Cambodians, 12% of Laotians, and 25% of Vietnamese have college degrees, compared to 71% of Asian Indians and 74% of Taiwanese. We know that income levels are also dramatically lower in these referred to as subgroups. So I can only infer that their COVID rates and their vaccination rates are drastically poorer. We think that an overall strategy to improve everyone's health, to do that, equity really requires special efforts to improve the health of those most vulnerable in Connecticut. And thank you, I heard that bell. And we know Connecticut has already made progress here, and they've made a real commitment in it. But unfortunately, aggregated data can be a tool of discrimination and exclusion, which perpetuates health disparities on a macro scale. And that's why we're advocating for REL data, particularly disaggregated into the smallest communities, so we can help deliver culturally and linguistically appropriate care. Thanks again for having me.
Thank you, Professor Buckley. Thank you for sharing your refugee and immigrant focused lens with specificity to the South Asian community and the inequities of the data in that community, the need for disaggregated data, and the problematic microaggression of the model minority. So I hear you, we must not remain mute. Angie? So if Angie has dropped out, she may not have been here. So let me throw it now to Reverend Nancy Kingwood. We appreciate you being here, and please just give us an overview of why you do the work and how it impacts your organization, briefly.
Well, thank you so much for the invitation tonight. I am, as she said, Nancy Kingwood. I'm CEO and president of GBAP, and I'm also part of Mount Airy Church family. So thank you again. And so I've come to this work. I've been doing nonprofit work for about 27 years. And I started engaging in congressional briefings in the Rayborn building in Washington for about 18 years. I will go 3 or 4 times a year to kind of tell our stories. What is our local stories? And if we're going to tell our stories, we need all information, all data. If we're going to tell the story, we have to tell the whole story. And many times as I would go and present to Congress, I always felt that was part of our story that was missing. And I really got involved in health equity work when I became a fellow at the Connecticut Health Foundation. I believe it was in 2012. and we'll really start to do a deep dive around the disparity and inequities in a small, relatively small state like Connecticut. The disparities are huge, especially in Fairfield County. And so my support for REL is that it would give us the information and the data that we need to present our case. I'm also a grant writer, and I'm always looking for current and relevant data, because some of our federal funders, they give us funding based on client cost. We don't know the client cost if we don't have the full equation, if we don't have all the information. And I think that without REL, we are missing opportunities, we are missing funding, and we are also missing trends. What are the cultural trends? What are the trends in Black and Brown communities? We won't know unless we have access to this data. Again, and I think Dr. Buckley, and I think Reverend Anderson hit it square on. We need this information. Those of us that work on the front lines on grassroots level, those of us that work in administration and also work in policy. Again, if we're going to tell the story, tell the whole story, tell everyone's story, so all of us can have access to quality health care. So all of us collectively together can help dismantle racial inequities that are, again, huge. It makes no sense if you have an insurance card, but still have barriers to care. Makes no sense if you have access, but you really don't have access. Makes no sense if you go to your primary care physician, but still can't have access to a specialized doctor. So again, I think it takes all of us to tell the story, tell the same story, and tell the whole story.
Reverend Kingwood, that was powerful. Thank you. We hear you. We need to tell the story, the whole story, but to do that, we need the data. And you, all of you who do the work in the community, you need the data. Thank you all for those valuable insights and the framing around the work you do. We certainly appreciate all of you. For the remainder of our time together, we'll be in conversation with our panelists about REL as seen from their lens. Questions were sent in advance. If you have a question, again, we ask that you put it in the chat, and we will address as many as we can given our time constraints. Now let's begin. Dr. Gonzalez, in your perspective, what problems might we be able to solve if we had REL data that we can't solve now? And it's a 2-3-parter. Can you give specific examples of how REL data can be applied to improve healthcare outcomes for people of color in Connecticut? I'll repeat the first part. Dr. Gonzalez, in your perspective, what problems might we be able to solve if we had REL data that we cannot solve now?
So let's just think of COVID vaccination. We know that there are terrible health disparities in COVID vaccination in the state. Doing well overall, but the disparities across racial groups are pretty stark. Nice to know, but where are those disparities? If you want to reach people, where do you go? Is my block well vaccinated and your block is not? Is my cousin's block well vaccinated and my sister's is not? We need to know down to the level of census tract who's been vaccinated. We need to know who has been at risk of. We could have instituted preventive measures and additional COVID prevention measures all throughout 2020 if we knew the neighborhoods and the census tracts, the census blocks that are highest risk. And now we can target vaccinations, pinpoint them with mobile vaccination clinics to a church, a synagogue, or a mosque near you, if we know where to go to bring healthcare to the people. You know, it's one thing to say, come get a vaccine here at Yale, or come down to downtown New Haven to get a vaccine. It's another thing to say that we're coming to you and help is on the way. And the only way we do that is by knowing who we need to reach, what the deficits are in the resources at a very local level, and being able to go out there and fulfill the needs in real time in real places.
Thank you, Dr. Gonzalez. We really appreciate your sharing that with us. And Reverend Anderson. Had we been collecting REL data at the onset of the pandemic, what difference do you think that would have made in our fight against COVID-19?
Thank you for asking that question. As we look at the amount of people that have died and the disproportionate amount of people of color that have died. But here in Connecticut, what was also so devastating was that they could not even give the statistics of the people of color that were dying.
Oh my God.
They had no data to actually put them in categories of the people that were dying of color. If you remember that, they knew it was a disproportionate amount, but they certainly did not know who they were, did not know the amount and the actual numbers. Why? Because of the way in which they do not collect data, especially on people of color, race, ethnic, and language data. And I think that if we had already had that in place right away, we would have been able to find that out and to know that. The other thing that also happened is that, you know, even with our initiative, what we had to do, we went door to door, making sure our people knew about testing, making sure that they knew about COVID-19, making sure that we gave them wellness kits to make sure that they were able to, have the supplies and everything else that they needed. And to me, it wasn't until really when they found out the disproportionate amount of people were dying, but also the fact that I think about even now, and I wonder about this sometime, would, all of the things that we talk about, and it is, yes, it is hesitancy, but that does not mean refusal. But it means that, again, people of color, as I mentioned to you also, does not trust the healthcare system. And so it's around vaccine confidence. And then also being able to come to us and also ask us to come and be a part of an advisory council, also to ask us to help our people to get vaccinated, and we run a faith-based clinic every Tuesday. But the thing is that the sad part about all of this is that because in order for us to obtain herd immunity, we have to have people of color getting vaccinated. And so, but that doesn't mean that you really cared about us really being alive. And that doesn't mean that you really are concerned about us living and getting those things in place that need to be in place so that we are able to stay healthy even beyond the pandemic. So again, to me, the pandemic, it took off the covers of racism as it relates to the healthcare system and the inadequacy that had already existed. And if we really go back and look at it, we've been here before 100 years ago with the Spanish flu. And the same thing happened that they weren't able to collect data because there was nothing in place. And here we are another 100 years later, and we're still in the same place. I just think that it's about time, if we really say that we really want to, and we're serious about making sure that we're concerned about the healthcare of others, then we need to also do those things that would help us to have the healthcare of others. One more thing that I actually really want to mention that I think is important, that even as it talks about affordable healthcare, and also as we think about also the fact that Husky A, and realizing and knowing that the federal level, if it's not raised, that a lot of people will not have insurance. If we had race, ethnic, and language data, then we would automatically really know some of those things and standardize some of those things, that we would think about those things when we look at, okay, where are people at? Who are they? Where do they fit at? Where's the standardized data? Oh no, that's going to interfere. We have to make sure that if the minimum wage is actually raising, then we need to make sure that people still have health insurance. Because if we don't, then this population is at risk of even dying even more in large numbers. Thank you.
Reverend Anderson, thank you for bringing us that information. It really brings home to us how important REL data collection is to helping dispel those disparities. Thank you. Deirdre?
And now, next up, Professor Buckley, could you speak to why collecting not only racial demographic data, but race, ethnicity, and language data is so important? Professor Buckley?
Yes, thank you. And thank you, Reverend Anderson, for your words. They are so passionate. I love your I love your commitment and your passion on this topic. It's I could listen to you every day on this. Let me just say that, you know, the obvious answer to that question would be looking at what the Agency for Healthcare Research and Quality says, that you know, any minimum data set related to healthcare quality and quality improvement needs to contain language and communication needs, as just no, there's no way around it. But more than that, what we know is that there's a huge body of literature now that links language barriers with poor quality healthcare. And we know that when a provider and a patient both speak the patient's primary language, it results in greater patient understanding, increased satisfaction for the patient, better medication adherence, greater understanding of diagnoses and treatment, and greater overall well-being. And what we also know from the data is that when patients and providers are discordant, meaning that they don't speak the same language as their primary language, some but not all of these effects can be mitigated by having trained interpreters. And I emphasize trained interpreters, not family members. We had an unfortunate case a number of years ago where one of our Cambodian patients could not speak English at all, could not get a translator. This is before we had many community health workers to be able to go with our patients to the physician. And her 6-year-old daughter was told by the physician, she acted as her interpreter, was told by the physician that her mother had cancer. And she had to now explain to her mother that she had cancer. So now we, as healthcare providers, as in a trauma clinic, are now left with 2 trauma patients, not just the adult, but the child as well. We did a study 6 years ago with the Connecticut Asian Commission, which was a needs assessment of Southeast Asian in Connecticut. And I'll just give you just a quick data snapshot of why language is important. One of the questions we asked had to do with health insurance and access to physicians. And almost everyone we asked this to, and this was Vietnamese, Laotians, and Cambodians in Connecticut, almost all had health insurance and a primary physician. And over 2/3 had seen their physician within the last year. But more than half of them had a language barrier with their physician. And those that needed an interpreter, almost 3/4 indicated that a professional interpreter was never or rarely available for their healthcare visit. So I mention this because to me, it indicates that while access is good, and while we can be sometimes confused by the data saying that the access looks good, we might not have access to culturally and linguistically appropriate healthcare. And that may be not as good as what the data is showing us.
Thank you, Professor Buckley. We appreciate that. Angie, you were going to introduce our next speaker and the question.
Angie, you're on mute.
Is that any better? Yes. Okay. Sorry about that, and thank you. Reverend Kingwood, please tell us why REL is important to the work of GBAP, Greater Bridgeport Area Prevention Program, and what you want legislators to understand about healthcare disparities in Connecticut.
Thank you for the question. REL is extremely important to the work that we do. And here's an example. GBAP is the lead organization for Ryan White Title I Part A funding for the city of Bridgeport. We are always asked to complete community needs assessments. We are always asked to submit relevant data. And one particular funder that supports that work also will fund us according to cost per client, cost per person. And if we don't have access to relevant data and to REL data, we are missing out, and I believe I spoke to this earlier, on funding opportunities. So through this initiative, our partners are Southwest Community Health Center, Optimus, Liberation, as well as RNP. And so GBAP, we pay the salaries of over 30 people that work in the field. We definitely know that every year we get a hairline cut in funding because we don't have relevant data. And when we go back to the Regional Planning Council, they're always asking us, what does your data look like in your region? This will help support us in obtaining federal funding, which is extremely important to help building our infrastructure, not just at GBAP, but of other nonprofits that are also doing the work. I want legislators to know that this initiative, REL, is so important to their constituents. If we want to have a healthier community, if we want healthier people, again, we have to know where they are. We have to know where they are. We have to understand their needs, especially in urban communities, but also in Black and Brown communities. And I think Vicki said it earlier when she first started, that when in her opening comments, that if we're not going to do it now, when are we going to do it? Because I think the time is right to do it when we look at the existing data and still say it's still not enough. I can't tell you how oftentimes that when I do congressional briefings, of course, pre-COVID, that I would always be stretching to tell the stories of how federal policy and how federal funding impacts local communities and individual households. It's the same thing with state legislators. They really need to know that this data will also help the communities in which they serve and which they represent.
Thank you, Reverend Kingwood, for that. We hear you saying what gets measured gets funded.
Yes.
Relevant and real data is necessary. Legislators need to know that this is important to their constituents, and the time is now. What I'd like to do is, there are those of you attending, it's our teach-in tonight for REL. Thank you to all of the panelists. We know that there are a couple of questions. We'd like to see if we can get to 2 or 3 of those tonight. If we feel that we're about to run over time, we will certainly ask your permission for a few more moments towards the end. So, do we have a question from the audience?
We do. One question that came in, specific examples of public infrastructure that will be needed to be improved to act on what is learned from REL. Can one of the panelists name a specific infrastructure that will be needed and can be improved from what we've learned from REL?
So can one of my panelists jump in if that speaks to you?
I mean, I don't know. I think, so look, we have to get data from the bottom up, right? We don't have county governments in Connecticut, so there's no county health departments collecting what the towns do. So, so I work on opioids and overdose, right? And I'm interested in emergency medical services data. Guess what? Every town in the state has their own format for collecting the data, their own format for reporting, their own format for sending it up to Hartford and to the Department of Health. The point is we're going to have to harmonize across the state. We're going to have to provide resources to the local level so that not just COVID data, and it's not just data that comes through the a medical record or the the electronic EHS record, all the data on testing for COVID or for whatever we're talking about. So we're going to have to figure out local infrastructures that it's at the level of your towns, up to the level of counties, up to the level of the rest of the state. And that doesn't exist. We lost 50,000 public health jobs in the United States after the 2008 financial crash, and they never came back. Connecticut has a handful of people doing work on COVID now that have permanent positions. So there's really no human resource infrastructure of public health in Connecticut to speak of. It's all contract-based and consultant-based. And so my big thing is about people power and the idea that we could use the American Rescue Plan to pay for some of this at least for the next few years, while we figure out a more stable source of funding for this. Because telling the state to do something like collect this data becomes an unfunded mandate if you can't pay for it. And the American Research Plan money is the way to pay for it. And as I sent out some links in the chat, it's totally flexible. This is the most flexible money we're going to get from Washington in our lifetime. It's a huge amount of money. And it's very, very sort of open to the discretion of states and localities about what to do with it.
And I would like to say also that, to me, the infrastructure also would be, even on the public health level, the Department of Public Health, that there would need to be some kind of, whether it's a department or something that's set up, that there is to make sure that we standardize the way in which we collect race, ethnic, and language data throughout the state. As we make hospitals accountable, we make physicians, primary care doctors accountable. Also, we make sure that even down to the level of grassroots organizations, that they receive not only just training and education, but also they receive the funding that's needed to be able to put whatever things in place to be able to collect data from a perspective of race, ethnic, and language data. But I do think that it has to be, if we're going to really create an infrastructure, it has to start on the state level, and that dollars would be put into the Department of Public Health, or from the Department of Public Health, whatever dollars they have, that we would actually have a department that would handle race, ethnic, and language data. But also, even the rollout of it is to make sure that agencies, down to grassroots organizations, have the funds that they need to set up their data system so that they can collect this data also, and also a way in which we can actually retrieve this data in a centralized way.
Great points. I'm glad this is being supported. Great, great points. Another question that came through, a real quick one, was, does anyone know the size of the Asian population in Connecticut?
I could take a crack at that one. It depends on how you define Asian. The Southeast Asian population is also variable as well. And this is one of the problems we have. If you're just looking strictly at census data, it will give you inaccurate data, that we know for sure. But we know from the work we've done with the Vietnamese, Laotian, and Cambodians that roughly the Laotians and Cambodians roughly are between 3,000 to 4,000. And the Vietnamese are a little more than double in that. However, that doesn't include the Burmese that have come in, especially in the last 10 years. And the Burmese have come in a variety of different ethnic groups, the Karen and the Karenni. We know in Hartford, for instance, is a very large Karen population. We have no data on that at all. So I think it's important to know when we just say, what's the Asian census? And again, this is why I emphasize disaggregated data as being so important. And we know that all races have many, many disaggregated data points that they could collect. And that's why it's so critical. As was mentioned by one of our speakers, the importance of collecting it just to know specificity. I can tell you, as people have looked at some patients, we don't even have textbooks that show us certain skin conditions that specific ethnicities will have that we know how to treat. They're not even in the textbooks. So that alone shows us how that we're biasing healthcare in certain ways.
Thank you for that. Last question. What community outreach / education do you anticipate to ensure that those most at risk feel safe answering the questions REL, what's their race, what's their ethnicity? How do you address that, helping people feel comfortable giving that information?
I think one of the things is that, really an overall effort throughout the healthcare system, one, to make sure that, Black and Brown communities have equal access to healthcare. And also that the healthcare system also is educated to be able to address the needs of the Black and Brown community, but also invest in making sure that we have medical staff that actually looks like our population, that are diverse, in a diversified way as well. Because it is, a question of how do we collect data from people when they don't really trust the system. And so a big effort would have to be really around why should we, how can we trust the system? And even as we look at being able to dismantle racism, we have to look at, whether redlining, housing, police reform, and all of those things are still all tied into also having this collection of data, but also the impact on public health and on health. So I think that again, it has to be really a way, and we have a brief that's called radical healing, and there's various ways the radical healing needs to take place in the different kinds of platforms that it needs to take place in. And so, I think that, we have to really think about and talk about various kinds of things in terms of how, we do, what kind of impact we've already had that people distrust the system. And then you want to collect data on us all of a sudden now. And so we have to have a way in which we educate people, but also that we're willing to invest in those things that will help us to help people to gain their confidence in the healthcare system so that they are able to collect race, ethnic, and language data because they see the improvements of the healthcare, of our healthcare, and the efforts to improve our healthcare, and the efforts to diversify the workforce and those kinds of things that on every level that affects us and affects different populations. And that someone said earlier that we have, and because we know that, we also are able, because a lot of people have been mislabeled and not even cared for because you didn't even really understand the diseases. So again, I think that a part of that is that when you have people that are, it's a diversified population, they have a better understanding of maybe, different kinds of health diseases and different kinds of things that have an impact on people.
Thank you very much. Thank you.
Thank you for those questions. Thank you for your comments in the chat. I'd like to add on to Reverend Anderson. You said that we don't trust the healthcare system. I'd like to add on to that. The healthcare system has not always been open and transparent with communities of color, and they have mistreated us. So I would even shift the lens a little bit, right? Thank you all for that. I wanted to go through, but I see we have about 5 minutes to our meeting. So let me now say thank you to all of you for joining. Representative, is it Mike D'Amico? Is Mike D'Amico on our call tonight? I just wanted to recognize, I thought I saw his name. Thank you to the pastors and the teachers and the preachers on the line, the business people and the legislators who are concerned about this life and death situation. Now, Angie, do you want to recap for us? And we have some homework for all of you. This is a teach-in, right? So you have a little bit of homework.
Well, as Deidre said, I hope tonight you have been given something to think about. I know I feel educated, and I thank you for that. There's a lot of work to be done, a lot of funding issues, collection of data, disaggregation. So many things have been brought into perspective. So again, thank you everyone for being here tonight. A big thank you to our esteemed panelists for their time and insight, to Health Equity Solutions for their collaboration, to the CONECT team of volunteers and organizers who are the architects of this event, to our audience. Without you, there would be no forum. So thank you to each and every one of you who made the time to understand and share about REL. We are committed to understanding and eliminating health disparities and improving the quality of life and life expectancies of all, especially the underserved communities. REL data will be essential in lighting our path as a state and a society. But this won't happen by itself, you know that. We have to speak up and demand that this critical but basic step gets taken this year by passing SB 1 or HB 6424 or both. We hope after hearing from these experts, you are ready to raise your voices again with your legislators to make this happen. We need your support. Please follow the Action Network link in the chat so you can send on your letter of support to your legislators. Please sign up to attend CONECT healthcare team meetings and to support our work on REL. Please invite your friends, family members, members of your congregations to join us in this. Please share this message with as many people as you know. And finally, understanding the importance of REL, please consider answering the questions when your doctors ask. Thank you. And now we invite Reverend Anderson to close us out in prayer. Reverend Anderson.
Thank you so much. Let us pray. Eternal God, we come today, oh God, thanking you and praising you that you allowed us, oh God, to come together, oh God, to discuss race, ethnic, and language data and the importance, oh God, of that continuing to come forth, oh God, in the bills that are passed so that people will have complete access, oh God, to healthcare, oh God, that God, that they may live and that they might not die. And God, we ask, God, that you would continue to guide us and direct us, oh God, and help us always to be so mindful, oh God, that you are concerned about each and every one of us, and that it is your desire that everyone would be in good health, as their souls prosper, no matter what their race, ethnic, or language is, oh God. And so, God, we pray, God, as we continue to go forth, oh God, that God, that we would see changes, oh God, in our system, oh God, that we will see changes in our world, oh God, and that we will see a people that have a mind, oh God, to continue, oh God, to have the concern for each and every person, no matter what color their skin is, oh God, but they realize and know that everyone has a right, oh God, to be healthy, oh God. Everyone, oh God, has a right, oh God, to have the health care, oh God, that will continue to help them to stay healthy. Thank you for the work of CONECT. Thank you, oh God, for the work of Health Equity Solutions. Thank you for the work of the Connecticut Health Foundation and also each and every person, oh God, that's on the line today, oh God. And God, we pray that you will continue to give us the fortitude, oh God, that you will continue to energize us, oh God, and that we will not stop, oh God, until the work is completed, that everyone, oh God, has the right, oh God, to health care, oh God. Everyone, oh God, will have their health care concerns met, oh God, and that every health disparity, oh God, will be addressed, oh God. And so, God, we thank you right now for a new day, oh God. And we thank you right now for healing that will continue to take place, that we might continue to go forth, oh God, and be the people, oh God, that you're calling us to be collectively, oh God, and also, oh God, that we would live and not die. It's in your great name we pray and thank you. Amen.
Reverend Anderson, thank you